The thing about Jeffrey is that he's been on Capitol Hill forever, and he knows so many and he knows so much. And his memory is perfect, and his output is prodigious. And through it all, no matter what inflammatory issue is being discussed, the voice is calm, the voice is measured, the argument is clear. And I think, well, why don't we just let him run the place? You know, why are we kind of fooling around and sending his articles off to the seats of power when, in fact, we should just make Jeffrey the king? Jeffrey Simpson.
Thank you, sir.
Thank you very much.
That's a complete setup. To follow Pablo, I think the greatest contribution I could make to ideacity is to yield my 17 minutes to the belly dancers, and I think I'd get it. Yeah, okay, you hear that? Where are those girls? Thank you very much. Many of you here have been to Europe, of course, and you've probably been to France. And if you ask a French person what makes you French or what makes France France, I think the answer will come back something like la civilisation française, la langue française, la cuisine française, les hauts et les bas de l'histoire de la France. If you go to England and say, what makes you English? They'll probably say Shakespeare, these days maybe the monarchy, Battle of Britain, the English language, parliamentary government. If you go to the United States, they'll probably say the Constitution, the Founding Fathers, our military history, etc. Here in Canada, there's a lot of public opinion evidence about what non-Quebec Canadians say, which is what defines you as Canadians more than anything else. What are you most proud of? What's most self-definitional? And the answer is healthcare. By a wide margin, actually, more than hockey, and more than bilingualism, multiculturalism, the RCMP. We are the only people in the world who define ourselves by our healthcare system. And I mention that because I want to say a few things about that system today, and I want to indicate that we really need an adult conversation about healthcare in this country, but it's exceptionally difficult to have one because it's existential. If you ask any questions about the healthcare system, it's unpatriotic. It's, you're casting doubt on the nature of the people, i.e. English-speaking Canadians. It's different in Quebec, because in Quebec, of course, if you ask them what makes you Francophone Québécois, they're going to say, 400 years of history, la langue française, and so on. But here we are in English-speaking Canada, and our principal existential definitional question is healthcare. And everywhere I go in the country and I speak to premiers or deputy ministers, etc., and I say, what's the number one issue facing your province? They say healthcare spending. I say, well, why don't you say that? Oh, Jesus. I'd be hung by a lamppost if I did that. So we have this problem, or this issue, this challenge, which I want to say something about, but we can't have an adult conversation about it, and that's kind of too bad. We live still under the, shall we say, the implications of the report that Roy Romano did in 2002. And what he did in 2002 was to say the system needs more money, and he said the money must buy change, not more of the same. And he had some other general views. Now, when I say self-definitional, you see what Mr. Romano did here. Mr. Romano took this up because I think he was reflecting what he heard from Canadians. And he described Medicare as a right of citizenship, the Canadian way, moral enterprise, public trust, defining aspect of our citizenship, expression of social cohesion. That's a little bit over the top for an important public program. Then he suggested something which actually didn't see the light of day. He wanted there to be a covenant. Now, those of you who are of a religious persuasion know that covenants are between an individual or a people and God, or their God. And in international law, a covenant is beyond normal treaties. It's something that's more internationally sacred. So you have the International Covenant on Human Rights. But this is the kind of rhetoric that we have about healthcare in our country. And he recommended that there be a cash payment of $6 billion, and this was the Romano gap. And so that was the solution: more money, money by change, rational planning, improved public care. Okay, so then the ministers got together and they agreed to put $41 billion into the healthcare system, indexed at 6% a year. Now, I don't know about you, but I would love my salary to be indexed at 6% a year. But that healthcare is so important that it gets indexed at 6% a year. And this agreement was supposed to end in 2013-14, but in the election campaign just passed, a typical example of what happens in healthcare is you don't have a reasonable debate. So the Liberals said, we'll extend this for 4 years, and then Mr. Harper said, oh, we'll extend it for 2 years. So that's where we are. Now, if you can see this chart, we're here near the top of the big spenders. This is 2007. Actually, if it were 2009, we'd be out here at 11.7%. I'm sorry, this is out of date. Here's the U.S. at what's now 18% for the U.S. I mention the U.S. because everybody who wants to defend the status quo of Medicare in Canada always brings up the U.S. Chrétien used to say, down there, they check your wallet before your pulse, and people would get pretty nervous. And anybody who wants to ask a question about our system and say maybe we should re-examine things, bang, you're immediately accused of wanting two-tier style U.S. medicine. Well, there's almost nobody in Canada who wants that system. It's a bogeyman, and we should get it out of our minds. We should instead focus on where we're at vis-a-vis some of these other countries, right? And the interesting thing about it is, so we're among the big spenders here. But if you look at international comparisons, and I know that they're very vague and they're difficult sometimes to get the data to match up, the outcomes from our system are actually kind of in the middle. If you look at OECD data, if you look at the Commonwealth Fund that ranked 7 systems, they ranked ours 6th. If you look at the World Health Organization, we're really down below the middle. So we're spending on a kind of Cadillac basis up here, but we're actually getting Chevrolet results. And that isn't what we're constantly told. We're always told we have the best healthcare system in the world, but there's no international evidence to support that proposition. It's not a bad system, but it certainly isn't as good as you'd expect it to be for all this spending. And this is where our spending has been. We're going up every year by about 4%, but that was taken when inflation was 2% or more, so we're going up about 6% a year. And as you can see from this chart, where's Canada? Canada's over here. 70% of all the money we spend on healthcare is public. But look at all these other countries that actually spend more on healthcare as a share of GDP than we do. That's another way of illustrating the same thing. This is where spending's been. This is when Medicare started, and this is where it is right now. So you can see what the trend line is. Right here, there was a pause when Martin and Chrétien conquered the deficit in the mid-1990s. But as soon as that was over, healthcare spending resumed its upward trend. And you can see the same thing. Here's the Martin Chrétien years, and here's the yearly spending, 4%, 5%, right there. That's what we're doing. This is another way of looking at it. We started at 7%, we're now up close to 12%. David Dodge, who used to be the head of the Bank of Canada and Deputy Minister of Finance, just published a paper that said if we keep on this spending trend, we're going to have 18% of our GNP on healthcare in about 20 years. And even if we get huge efficiency gains, he said, we'll be at 15%. Same idea, healthcare expenditure going up. Why is it going up? Well, aging a little bit, the population's getting older, population grows, inflation, but it's mostly increased use of services, and so that's drugs and visits to the hospital, and also payments made to doctors. You'll see another chart here in a moment. That's where the money's been going. Same thing. Now, this is why the Canadian system is so odd. It's odd because if you go to the hospital, almost all your costs are covered. If you go to see a physician, they're all covered. But everywhere else, there are all kinds of gaps. So here's drugs. Look, private spending's 62%. Most seniors have some kind of a drug plan. Everybody else has to have private insurance. You go across here, it's this weird system that's really, really public in 2 important areas and not very public at all elsewhere. So if you leave today and get hit by a car, you'll pay for the ambulance, you'll pay for the crutches, you'll pay for the wheelchair. When you're dismissed, you'll pay for physiotherapy, you'll pay for the drugs at home, unless you're on a senior's plan. So if you think of healthcare as a continuum, we cover in the middle, but we don't cover the rest. So there, that just shows where the money goes. It's hospitals and drugs and physicians. And hospitals are actually going down. As any woman knows, when you have a baby these days, you're out of there practically as soon as the baby's out of the womb. So we move people out of the hospitals very, very fast. Now, where did all that Romano money go? Where did it all go? We got about 30 billion of the 41 billion we've already spent. If there are any doctors in the room, I'm sorry, you're not going to like this slide. This is physician health expenditure. Look what happened. Here comes Romano. The physicians and the nurses unions grabbed a lot of the money. So when people say to me, let's put more money in healthcare, I'm prepared to listen to the argument, but I'm asking people, tell me how we stop the providers from grabbing a disproportionate amount of the money, because that really doesn't help patients. Here's what happens when the population gets older. The black is where our population was in 1998. Here it is in 2007. You can see it's getting older, right? And as it gets older, what happens to hospital expenditures? Well, you can see you get more people in this age category, and per patient, of course, the costs go way up, and we've got more of those people coming. Same thing there. You know, when you get over 70 years old, the healthcare costs per person go up a lot. And this is the problem the provinces have right there. This is their health expenditure, and this is their revenue line. And how to close that gap, because healthcare keeps going like that, and their expenditures are going like that. In other words, the problem's going to get worse, not better. Now, Ray J yesterday, Professor Ray J talked about astrology, and that's how he spends his time. I spend some of my time studying provincial budgets. Who would you rather invite to dinner? Don't answer that question. All the provinces are basically in this range of 44, 47%. That's where their budgets are right now. So let's just do a quick romp here. This is what Dwight Duncan said. 20 years ago, 32 cents we spent in Ontario on programs on healthcare. Today it's 46. Next door, Mr. Bachand said it used to be 31, now it's 45. In Quebec, next door, you can see exactly what's happened over the last number of years. Healthcare has gone up by this amount, and program spending for the rest by that. In the last 4 years in Quebec, the health budget went up 3.5 billion. The total spending went up 2.7. Something had to give by definition. And what gave, of course, was employment was zero, justice was zero, family went up, transport went way down, sustainable development, natural resources, economic development. Every budget practically went down except one or two. We'll go through that. Here's Ontario. So what have we been doing? Well, we had 8.5, 9.5, 7, 6.8, 6.4, and 6. And in the last provincial budget, our budget, the government said for the next 3 years they're going to reduce the increase to 3%. That's never been done in the history of Ontario by any government, no matter how hard they tried. Healthcare costs were 8% in that period, 12.1%. So it hasn't happened. In the last Ontario budget, the healthcare goes up 5%, overall expenses 1.7. Again, something has to give. And what gives are the other budgets. Justice, welfare, roads. Don't complain about potholes because you know where the money's going. This is Manitoba, okay? So health goes up by 116, and tourism goes down, justice goes down, highways go down, education go down. This is Saskatchewan, okay? Healthcare goes up, there it is, going up. All these budgets go down, every one. Agriculture, education, highways, environment, tourism, okay? British Columbia, same thing. All the ministry budgets go up by about the same as healthcare, which means the others have to go down. So housing goes down, forests go down, children and family in real terms go down. This is very interesting. This is our richest province, Alberta. 20 years ago, the Alberta budget was 26% health, 26% education, 11 social services, and 33 for the others. In the last budget, health had gone up to 44%, education had dropped to 23%, social services had gone down a bit, and the other programs had dropped by 10%. That's the richest province. So we have options. And unfortunately, we can't have an adult debate in the country about these options. And we should have an adult debate because you've just seen what's happening. Now, one option is to borrow some more money. I mean, in Ontario, we've got debts for the next 5 years. We could just add some more debt. You know, our country, as a general rule, isn't in that bad debt shape, so we could borrow for a while, kind of kick the can down the road. We could raise more revenues and put it all into the healthcare system. We could impose user fees. which is the great no-no of Canadian healthcare. I just spent 3 days in Sweden, which is a far more egalitarian country than we are, much greater social democratic tradition. They've had user fees to see a doctor go to the hospital forever. And when you ask Swedes, why do you have user fees? They are perplexed by your question because there's no discussion or debate about it. They simply believe in Sweden, maybe they're wrong, that it's useful to have a small fee because it deters excessive use, okay? And if you're on welfare, you don't pay, and there's a cap, a ceiling, okay? If you go over that ceiling, you don't pay anymore. So we could do that. We could put on premiums the way Mr. McGuinty did when he got elected. Alberta took them off. We could raise the premiums. No reason why you can't raise the premiums and put all the money into healthcare. We could put on a health tax. Quebec did that. They're going to raise $1 billion next year for this health tax, which is geared to income. So when you fill out your income tax form, there's going to be a section for your health tax, and all that money's going into the healthcare system. We could raise personal income taxes. They're the most progressive taxes we have, so we could raise personal income taxes. We could raise the GST by 1 point. The Prime Minister cut it by 2. That cost us $12 billion. We could add 1 back. That's $6 billion. Put it all into healthcare. So there's lots of different ways we can raise revenue. But remember, we're already spending among the highest amount per capita in the world on healthcare. So the question is, do we want to put even more in there? And if we do, how do we get it in there so that it actually helps patients and doesn't line doctors' pockets and nurses' unions? We could cut spending on other programs. That's what's been happening by stealth. I showed you the numbers. You see, because nobody has a serious conversation about this, most people don't know what's happening to the other budgets. It's because, as Don Drummond from the TD Bank said, healthcare spending is like the pack monster. It just kind of eats up whatever's available. So we could consciously do that. I could give you easily ways that we can cut spending. We can put tolls on all the roads. We could raise student fees at universities even more, so the government has to pay less. We could reduce the welfare rates. There's lots of different ways we can spend less on other programs. We could make efficiency gains, and there's lots and lots of those that we need in the system. And we could actually help, no doubt about it. My view is that those gains are necessary but not sufficient. Or we could change the system and have more private money so that you'd be able to buy healthcare. In Australia, our Australian cousins have a parallel private system, and they're so keen to have it that over a certain income level, if you don't buy private insurance, you have to pay more income tax. In other words, there's a penalty if you don't buy private insurance. And doctors work on both sides of the system. So lots of countries have this. All I'm saying to you is we need to have a conversation about a system that is quite expensive by world standards, that's only producing by international comparative standards average results. And unfortunately, unless we can have a conversation, we're going to be imprisoned by those charts I showed you where the spending keeps going up, the other programs suffer, and we're still getting middling results. I hope we can have that adult conversation because we really need it. Thank you. Thanks, sir.
Beautifully done, beautifully timed. That's good.
Good.
So pleased you finally came.
Thanks.
See, what did I tell you? Huh? Perfectly clear? I don't know why we just don't do that.